It's a rather rare condition. It affects about 1 in 10,000 children. However, it can be a potentially devastating condition. So pediatric glaucoma is a very different disease process from what we see in adults. Children who are born with glaucoma, probably one of the only good things about it is that we can often cure it with surgery. So it's not amenable to treatment with topical medications like adult glaucoma. So if we operate early enough, we can often reverse a lot of the changes that these children have, and we can give them pretty much a normal life if we can get to them early enough and provide the intervention they need. About 20% of the children who get congenital glaucoma are born with it, and about 80% will develop it within the first year of life. It is not one of the easier conditions to diagnose early on, as we can't use sort of conventional means to measure eye pressure. We have to sort of go with some of our gut instinct. The children often develop rather quickly, but it's the parents that are really observant that end up picking this up early. So what we often see is there's a classic triad of signs, and children often have photophobia, so they have not maybe a fear, they're an aversion to light, and that's because of swelling in the cornea, which is the front of the eye. They tend to blink a lot, and they tend to tear a lot. The other thing that the parents tend to notice is also the change in the actual properties of the eye. The eye grows rather large quickly. So these children have very big eyes, and the front of the eye tends to get swollen and filled with fluid, and it has this blue-grayish appearance. So the clouding of the cornea that we see and the size of the eye are two sort of key diagnostic criteria for us as clinicians. When I look at a baby, often it's sort of a gut feel. I'll look at the eye will look large, and I'll then have to take them for an examination. I don't think so. So the pediatrician is often very good at funneling anything that looks abnormal to the ophthalmologist, as they should. The pediatricians are often just looking to make sure that there's a good red reflex, which is what they're taught to look for in children. Children with a poor red reflex can have a host of diseases, and that's where we come into play. We will sort of determine what's going on. When they make it to me, often I will do the best I can to do an exam in the office, but often we have to go to the operating room for an examination under anesthesia, which carries its own associated risks. So we try to be as certain as possible that that's what the child needs, but if there's any uncertainty, we often will go. So typically, we try to get all children that need eye exams to a pediatric ophthalmologist. In terms of glaucoma, it varies. There are certain pediatric ophthalmologists that have training in glaucoma, and so they will be able to manage the child. And there are some adult glaucoma specialists who learn how to do pediatric glaucoma, so there's plenty of overlap. And if it is a glaucoma specialist like myself who's following them, I work very closely with our pediatric ophthalmologist, because it's not just about fixing the glaucoma. These children, because the eye grows so large so quickly, they end up developing poor vision, and you really need the help of the pediatric ophthalmologist to make sure that even if the glaucoma is taken care of, that these kids develop good vision. Again, that is one of the most rewarding parts of this, of taking care of children with this disease, is that you can often fix the problem, which is not often the case with adult glaucoma, where we're just trying to slow it down or stop it, with medicines, and it can be a very difficult disease. With children, the theory behind why they get glaucoma is that there's something with the development of the eye that goes awry. So these children either have a membrane that forms over the drainage canal, or one of the structures just posterior to the canal inserts a little further anteriorly and blocks the canal. So what we're trying to do with surgery often is to reestablish normal flow. So if we're able to actually successfully do our procedure, often these children will have a very quick clearing of the cornea. The eye will stop growing quickly. And if all the rest of the downstream collector channels are working, they should have a pretty normal outcome, a pretty normal pressure after surgery. A lot of these children, yes, if caught early enough, a lot of the changes even to the optic nerve are reversible. Because the children's eyes are very elastic, they can expand, but then they will actually rebound after we treat it. So the key is really early diagnosis and being able to do the surgery successfully, because if the first surgery, which we often do, is on the drainage canal, if it's not successful, we have to move on to bigger surgeries which carry greater risk. Often these children recover fast. If it is a surgery done on the drainage canal, surgery probably takes about 30 to 45 minutes for each eye, and often they're sort of back to normal within a week or two, and at the first exam in the operating room, normally they look great. If they need more invasive surgery, such as a trabeculectomy or tube shunt surgery, which is what I prefer as my second surgery, that is a little bit of a longer recovery, and as I said, does have greater associated risks. So we really strive for perfection with that first surgery, because that, I think, is where we can sort of achieve the best outcome. The one thing to be careful of is that these children, again, as we talked about, as I've said numerous times, this is an anatomic an issue with the development of the anatomy of the eye. So sometimes even when you hit the canal, you'll meet resistance or you'll meet obstruction, and you're not always able to successfully do the procedure that you want. And you have to be able to adapt to those situations and move on to a different procedure that day if need be. A lot depends on the success of the surgery. So most of our surgeries are trying to open up the normal drainage canal. There can be scarring in the canal, and again, because the exact mechanism isn't so clear, and it is an issue with embryologic development, there can be some issue with some of the more downstream parts of the pathway. So even if we open up the frontmost portion of the pathway, there can be obstruction more downstream, and the pressure can still go up. So we sometimes still, even when we feel we are successful surgically, we sometimes still have to do more surgery because the glaucoma is not fully cured. So it's not 100% of the time that if you are successful with your first procedure that this thing is cured. They can still go on to develop issues with pressure down the road.